my note. But it's okay. Let me see the PowerPoint.
Yep, I'll bring it up now. Is it coming up full screen for you?
No, I don't see it. I think.
Here, let me just.
How do you need help?
Go to view.
Go to.
It was just working fine. Let me try one more time. Sorry. Apologize for the technical difficulties. There we go.
Okay, thank you. So I think I lost my note. My computer froze. That is okay. Let's do it.
Let me know when to skip.
Okay, no problem. So we are people with spinal cord injury. Everybody experience pain, and we deserve to have, as a people with spinal cord injury, we deserve to have a healthy body and improving our health. And we know we are fragile, and we may, how can I put that? And we have a lot of disparities, and pain is one of them. Sorry, I lost those in my notes. Okay, can you next slide, please? There's a lot of pain. So pains are two types: the pain we experience and pain. I'm lost my pain. I'm so sorry. I really lost my note. My computer froze. Let me try to find it out. This is really bad. Okay, so let's do it this way. So this pain is this presentation is about dealing with pain. People who spinal cord injury, how do they manage pain? And also here about real cases about people experience, and they talk about pain. Meaning of pain, what does it mean after spinal cord injury and chronic pain? How pain can be managed? There's a lot of way to manage your pain. There's either through pharmacological or non-pharmacological treatments. Can you go next, please? I participated in this study. This is at the Miami project. I was one of the panel interviewed, and I learned a lot from it, how to manage my own pain. I was really clueless about, I know I have a lot of pain, but I really clueless how to manage it. I know I kept moving on in my life, but I have a carpal tunnels, I have pains in my joints, until I really get into understand and get into that project, and I really understand how to manage my pain through non-pharmacal. This was an option for me, is using treatments that supplements. I use it from natural groceries and natural supplements, and really especially the thoracic pain, it's really helped me a lot. This PowerPoint is going to have a really basic information about mechanism and managing pain and pain treatment options. So can you go next one, please? Well, pain is defined by the International Association. It's an unpleasant sensory and emotional experience from actual or potential issues damage. The experience of pain depends on several different biological, psychological, and that term is called cognitive. Is that right, John?
Cognitive?
Yes, factors. Therefore, pain differs a lot among individuals with respect to how it feels, how it responds to treatment, and how it affects a person's life. This is the cycle of pain, because, like, isn't a pleasant pain influenced by where and how it serves, and it may cause anxiety and depression.
Okay, you just quiet, okay?
Cool. Well, there's two types of pains, from my understanding. Nociceptive pain, is that right term? I think nociceptive pain is generated when specialized nerve ending called nociceptors located
it's
through the body.
nociceptive pain, yeah.
Yeah, that's included. It's in everywhere in the body. It could be including in the skin or in the muscles or internal organs. Are activated by mechanical, chemical, or thermal stimuli. That may be harmful. You can see that how the pain signal transfer from the skin to the spinal and then ended up to the brain. But the other pain is it's called neuropathic pain. Can you go to the next slides, please, Casey? Yeah. Neuropathic pain can develop after an injury to the brain, spinal cord, or peripheral nerves, such as spinal cord injury. These pain types depends on several different mechanisms triggered by the injury that may cause and maintain pain even after the individual injury has healed. Neuropathic pain occurs in about 40% of people who suffers a spinal cord injury. We know sensory nerves exit the spinal cord at each level and provide sensation for a specific skin area of the body. For example, the nerves that exit the spinal cord at C6 level supply a part of the hand and so forth. Every level have it's pointed to different organ of the body. So people with neuropathic pain, they experience like needles, burning, numbness, tingle, electric shock. And you can see, the purple coatings is people, talking about their experience and how that pain feels in their body. So it's a pressure, yes, but not crushing. So how to manage pain? Most of pain types are occurred after spinal cord injury tend to be long lasting and can be difficult to manage. But always it can be improved by even taking care of yourself and by self-management or using non-pharmacal or pharmacal treatments. So most of the pain types occur after spinal cord injury tend to be long-lasting and can be difficult to manage. However, pain can improve over time, either by itself or because of pain treatment and self-management. It is important to discuss your pain treatment goals with your doctors. All people with spinal cord injury need to understand their pain and available treatment options so that they can become educated consumers. A good understanding of one's pain can be also lead to a better communication with significant others and family members and healthcare providers regarding pain. Also, learning from other people with a spinal cord injury, how they manage their pain and what experience they have can be very helpful. So why it's important to be an educated consumers or an educated spinal cord injury? Well, it makes it easier to manage your pain. Know what works for you and do not works for you. It saves you a lot of time and frustrations. You understand what kind of pain you have and what some of the mechanisms are. What are the treatment options are for your pain and how it may work. So, so some people approach the pain, they use medication, which is pharmacological treatments. I cannot really pronounce all those type of medications, but there is like a positive perspective and there is a negative perspective. People have like maybe reaction to it. People may cope with it, but personally, I try to stay away from pharmacological treatments. So next, please, Casey. So the non-pharmacological mostly approach to how to manage pain, which is self-management. How do you self-manage? How do you manage your pain? It's coping. There is a coping strategy. For example, be active. Get yourself busy. Cook, watch TV, go watch movies, and there's exercise and rest, electric stimulations, massage, acupuncture. All these ways, can help you to cope with your pain and manage it. Like yeah, for myself, I really I really stopped taking medication or pain medication, or even for spasm, that causing shaking in my body and pain, because I know that medication caused me a lot of especially when I took antibiotic, when I have like infections, urinary infections, and I did have what's so-called, Dr. maybe Daniel know it, the C. diff, which is caused me a lot of oh man, bloated and pain, and I cannot really go with my life. I really I need to stop taking that chemicals and pharmacological pills or treatments, and I ended up doing exercises, supplements, acupunctures, massages, and it helps me a lot. That's my personal experience. Can you go to the next page, please? So it's important to know that treatment does not always, or pharmacological treatment is not always the options. There is a lot of ways to deal with your pain and manage it. I would love to hear from you guys. If I don't know if you can open the mic here, or we'll just listen to after Dr. Daniel talks, and then we can open and see what people, how they manage their pain, and hope to learn from their experience and help other people too as well.
Yeah, thank you for putting that together, Wada. At this point, yeah, Dr. Kim, if you would like to maybe talk about your experience with anybody with spinal cord injuries and your thoughts on how to manage pain after spinal cord injury, that'd be awesome.
Okay. Yeah. So, a nice review as chronic pain in spinal cord injury world. I don't have to tell this audience that like with everything else regarding spinal cord injury issues, there is no one simple, easy answer when it comes to real life. As far as pain management, it requires multiple approaches and treatment modalities, just like everything else that you deal with, whether it's your bowel care, your bladder care, your skin care. There's no one simple treatment that takes care of everything. In fact, chronic pain in spinal cord injury patients, it's one of the most challenging conditions to actually manage. And like I said, you're all experiencing it yourself, so I'm sure I'm preaching to the choir when I'm telling you that. Now, as far as spinal cord injury, just as was mentioned during the lecture, yeah, there are two categories, right? Nociceptive pain, which is a fancy medical term for mechanical type pain, right? So whether it's musculoskeletal or whether it's due to, like, skin ulcers, it's physical mechanical pain. Like if you break your bone, you have pain. If you tear your ligament, you have pain. Okay. Then there's neuropathic pain, which is the more common type of pain in the spinal cord injury population. And that is more, of course, nerve-related pain, which can be due to peripheral nerves are affected, but more often in the spinal cord injury patients, it's due to the actual injury that caused the condition and can actually evolve into an even more challenging pain condition called central pain, which you may have heard that term. And central pain historically has been very difficult to treat because central pain, whether it's due to somebody who had a massive stroke or brain injury, or somebody who had a spinal cord injury, it's literally pain that is due to a central nervous system injury or dysfunction. Now, as far as medications are concerned, typically when you're dealing with a chronic pain condition, they will typically try to manage the pain, as you've probably seen, like in different levels. Initially, everyone tries to start with an anti-inflammatory, which I'm sure everybody's tried. And a lot of times that's not enough, whether it's over the counter like Motrin or Aleve, or with prescription like Celebrex or Meloxicam. So then you have to move on to, adjuvant medications. And adjuvant medications are like muscle relaxants, which again, especially if somebody dealing with spasticity, you could be on oral Baclofen, or you could be on Tazanidine, which actually works at the spinal cord level as an alpha-2 agonist, and that's a very effective muscle relaxant. That's not addictive and doesn't affect people's respiratory drive. But sometimes that's not enough, and people do require actual strong muscle relaxants, which in the class is benzodiazepines, right? And those are your, Klonopin, Valium type medications, otherwise known in their generics as clonazepam or diazepam. Sometimes the spasticity is so severe that non-benzo diazepam muscle relaxants like Tizanidine or even Baclofen aren't enough, and you have to use something stronger. And then neuropathic pain medication, because that tends to be the predominant type of pain in spinal cord injury patients, that's usually the one that's most commonly used. So I'm sure most of you have been on gabapentin, which is generic from Neurontin. And then there is its more potent cousin medication, which is pregabalin, known by the brand name Lyrica. And those are a couple examples of a class of medication which are called anticonvulsants, right? And anticonvulsants, as you've could probably surmise, was actually initially used for seizure control, because essentially seizures are what? Irritated nerves in your brain, right? That cause tonic-clonic seizure activity. And what the anticonvulsants do is try to decrease the excitability, of those abnormal firing neurons in the brain so that the seizure activity stops. Well, what they found is that can also be helpful for calming down the irritated nerves in the spinal cord, due to the injury. And so that's why those anticonvulsant medications have become popular. There are medications that like Tegretol or Depakote, known as carbamazepine or valproic acid, that are usually used for true seizure medications, that in the past were also used for neuropathic pain. Tegretol, for instance, carbamazepine, is also used for trigeminal neuralgia, for instance. That's one of the classic medications. The problem with those type of, stronger anticonvulsant medications that can be associated with more side effects. So that's the flip side of the coin, right? With any medication that's stronger, the flip side of the coin is there's also the more potential for side effects. So that's why usually people start off with gabapentin, or if that doesn't work, then pregabalin, which is Lyrica, because those, even though I know there's side effects that you probably experienced, some of you, like drowsiness or dizziness or, blurry vision, they tend to cause less serious side effects than some of the stronger traditional anticonvulsants, because Tegretol, for instance, can actually cause like cell count abnormalities, which can be, catastrophic. As in like gabapentin or Lyrica, they can cause side effects just like any other medications, but they tend to be more benign. Like they tend not to be life-threatening. Then there's the class of medications that are also used for neuropathic pain called tricyclics or antidepressants, right? Now, this is where, on the one hand, you can kill two birds with one stone, because if you can put somebody on a tricyclic antidepressant, they traditionally not only can improve nerve pain, but certain tricyclic antidepressants can be used at bedtime to improve sleep and, of course, improve mood, right? But unfortunately, sometimes when those medications are prescribed, patients will take it the wrong way and assume that the doctor is giving it to them because they think that the pain is all in their head. Like, oh, you're giving me antidepressant because you don't think I really have pain. You just think I'm depressed and you think that I'm making all this up, which is most of the time you're like, seeing a doctor who's prescribing it. That's not why they're prescribing it, right? There's a few, unfortunately, to be honest, there's a few doctors in the community that unfortunately do think pain is always in someone's head. I mean, I could go into like my colleague's office. If I wasn't wearing scrubs, I was just pretending I was a regular patient and I was asking for, a particular pain medication like Percocet. They were like, oh, you look fine. It's all in your head. I mean, it's unfortunate, right? That a few doctors may assume that, but the vast majority of doctors that have experience in this world, they know that you have real pain. In fact, your pain is more complicated than the average pain patient, and so you require more care. So when someone's prescribing you tricyclic antidepressant, I hope that you please don't take it the wrong way that, the doctor assumes that, oh, you're just depressed and that's why you have pain. We actually realize that your pain is real, but we're trying to deal with the neuropathic pain and also try to take care of some other issues that are associated with pain, because we don't think that you, or at least doctors like myself, we don't think that you are depressed and that's what's causing pain. We think because of your pain, you're depressed. You see the difference there? That's a big difference, because we believe your pain is real, but we believe because your pain is so significant and so frustrating to deal with, it causes depression and also can cause difficulty sleeping. And that's very different than a doctor who thinks that you're depressed and the depression's causing your pain. Okay. So I want to make that distinction. So that can be very helpful. And those are the medications like amitriptyline. Amitriptyline is the generic for Elevol. That's a very common medication that can be used both for insomnia and for nerve pain. But it's something that should be avoided in people who have a history of significant heart disease or arrhythmia, because they can increase the risk for an irregular heartbeat. That could be a problem. If you aren't having trouble with insomnia, then there are other medications in the tricyclic family, like nortriptyline, for instance, which tends to have less side effects. The side effects that are most common in tricyclic antidepressants are what's called anticholinergic side effects. And these are significant because when you have anticholinergic side effects, they can cause not only like dry mouth, but they can cause urinary retention, which is a problem, right? If you already have neurogenic bladder. It can cause constipation, which again is a problem if you have neurogenic bowels. So like, again, the amitriptyline, which is considered like a first-class tricyclic antidepressant, it's definitely effective and probably the most common tricyclic antidepressant prescribed for nerve pain because it can also help with insomnia, which is great. But again, because it tends to be stronger, can also cause more of those anticholinergic side effects that you don't want, you know, like dry mouth, difficulty urinating, and constipation. And then you may want to like switch to something else that tends to have less side effects, like nortriptyline. So those are the two classes of medications that are used for nerve pain. And the last but not least, opioids. Now, if you look at the literature, opioids traditionally have not been very effective for neuropathic pain, okay? They're usually used for nociceptive pain, which is that first type of pain we talked about, that mechanical type pain, that musculoskeletal type pain, like when you have a fracture or a ligament, you've got mechanical pain. Opioids are very effective for mechanical nociceptive pain. Traditionally, they've not been thought to be very effective for neuropathic pain. However, that doesn't mean that they don't help, okay? So there are certain instances, even in a spinal cord injured patient, where opioid pain medication management is necessary, okay? It's not obviously the first line or even the second line type of medication that's used, but spinal cord injured patients can have nociceptive pain too, right? If you've got like a huge decubitus ulcer, right? That's a source of physical pain, right? And in that instance, somebody may actually not be getting enough relief from an anti-inflammatory, muscle relaxant, or nerve pain medicine. They need opioids, okay? Obviously, because of, you know, disuse atrophy, the bones can get weaker too, right? And you can be more prone for like stress fractures, right? Or insufficiency fractures. That could be a source of severe acute pain. So even though in general, chronic pain is the predominant pain that you deal with in spinal cord injury population, it doesn't mean that there are instances where acute pain can occur, and when all else fails, opioids are necessary. However, when you use opioids, ideally you want to use it short term, right? Because of the fact that if you're on it longer, not only will you develop dependence, which is normal, but there is a risk of addiction. Now, I do want to mention here the difference between dependence and addiction, because in the general public, sometimes those words are used synonymously, like they're the same, when they're actually very different from a medical perspective. Dependence is a physical phenomenon. Dependence simply means that your body is used to having that medication. So if you stop it abruptly, there will be withdrawal symptoms, okay? That is very different though than addiction, because addiction is not physical like dependence. Addiction is psychological, and addiction is a problem, okay? Addiction is where a person has a craving for a substance or even a type of activity despite harm, okay? Now, when we're prescribing opioids for patients who are in severe pain, it's obviously not for harm, right? It's to relieve their suffering. When someone becomes addicted, though, they're using it not just for the pain relief, they're using it for the euphoria that they may experience. They're using it despite the fact that it may be ruining the rest of their life. And we already know like the risk of opioids. You have more difficulty. Again, with constipation, it's a big problem with opioids, and something that, unlike most opioid side effects, your body may not adapt to. Respiratory depression is a huge deal. So if you are a cervical spinal cord injury patient and your respiratory status is compromised, opioids, again, should be probably avoided long-term. But when it's an acute type situation, that is when short-acting opioids for, a couple weeks and maybe up to a month is understandable and indicated, okay? Now, let's say we're in a situation where you failed anti-inflammatories, or you can't take them because you have a history of gastric ulcers, or kidney failure, renal insufficiency. Let's say you try the muscle relaxants, but even though they're helping with spasticity to some degree, they're not helping with the pain that much. Again, if you have liver disease, muscle relaxants may need to be avoided because they put a significant stress on the liver. Let's say you've been on neuropathic pain medications, both anticonvulsants and tricyclics, and the bottom line is that none of that's really helping, and your pain is lasting for more than a month, right? Like the acute injury, whatever it may be, has subsided, but your pain is just out of control. Again, not ideal, but in that type of situation, transitioning from a short-acting opioid on an as-needed basis, which you were initially planning on hopefully just being on it for a couple of weeks to a month, you may have to transition to a long-acting opioid. And why would we do that? Because as you just discussed in your initial presentation on the slides, when you're dealing with chronic pain in the spinal cord injury patient population, usually the patients are experiencing some significant type of pain constantly, right? Just like your spinal cord injury situation is a chronic condition and something you're having to deal with all the time. And I'm not saying that this is the majority of patients, because fortunately the majority of spinal cord injury patients don't have constant severe pain all the time, okay? But I'm talking about a special subpopulation that, like I said, they've already tried all of the non-opioids, and the short actings, they've already been on it for a few weeks, and it's clear that the pain is not going away and it's just out of control. Then in that instance, putting them on a long-acting opioid, whether it's one tablet every 12 hours or even a fentanyl patch where you don't have to take it orally, that may be necessary. And again, you would start low to be on the safe side, but that may be something that is medically appropriate because they're having pain all the time. The advantage of the long-acting is you're not having to deal with the roller coaster experience of the short-acting opioids, where you get relief for a few hours, your pain's better, and then all of a sudden it spikes again. What's nice about the long-acting opioids is that you're not trying to decrease all the pain, right? Because in chronic pain, just like when you're dealing with spinal cord injury, the goal is no longer 100% pain relief because it's not realistic, right? Now, again, I'm talking about this subpopulation of spinal cord injury patients, not the vast majority of spinal cord injury patients, but the small subgroup where their pain is constant and severe and nothing else is working. Well, in that instance, again, the goal is no longer to take away the pain 100%. That's not the goal in chronic pain, whether it's spinal cord injury related or non-spinal cord injury related, because it's chronic pain. If it could go away 100%, it would have already done so, okay? Because as you said, there are certain types of pain that will subside with time, right? Unfortunately, in chronic pain, even though time has passed, a significant amount of time has passed, the pain has not gone away. So in that type of situation, the goal is no longer 100% pain relief, because that's a goal that's for acute pain only, okay? In chronic pain, we have to shift the goal to something more realistic, where it's to decrease the pain enough where a person's function or quality of life improves, okay? Because in chronic pain, if you try to take away 100% of the pain, that's where people overdose, because that's not realistic, right? Okay. So when chronic pain, I try to set realistic goals with the patient and say, look, we know 100% pain relief It's not possible in a chronic pain situation. But let's see if we can take away 50%, right? Because that could be the difference between being in agony, right, and being able to live your life, right? And that's where a long-acting pain medicine may be appropriate. Now, I'm going to give somebody else a chance to talk, but I've just been talking about pharmacologic, okay, right? There's so many different categories we use. But non-pharmacologic is where I think that there is a lot of promise in today's society. And I just want to, because are implantable devices, right? Like for people who have spasticity, so not related specifically with pain, but if you have severe spasticity that's not managed by oral muscle relaxants, like I mentioned before, Tazanidine or Baclofen, or even benzodiazepines like Klonopin or Valium, and the spasticity is so severe that the legs are shaking and it's literally causing a fall out of bed or wheelchair, then that type of they may need intrathecal Baclofen, right? And intrathecal Baclofen, you do a trial injection to see if the patient responds to it. But if they do, then that would be administered permanently through a pump. If someone's going to have an intrathecal pump because they need the Baclofen to control their severe out of control spasticity, which again, fortunately, is the minority of patients. It's not the majority. So that's a silver lining. Fortunately, it's the minority of patients that actually need an intrathecal Baclofen pump. But if they need that and their pain's out of control, then administering intrathecal morphine along with the Baclofen, again, you're killing two birds with one stone. And now, if it's pure nerve pain, there is an intrathecal medication called Prialt, which is a calcium channel blocker, because calcium channels are strongly associated with transmitting the nerve pain signal in the body. So if you have a calcium channel blocker, which gabapentin and Lyrica are also calcium channel blocker type medications in oral form, you can prevent that nerve pain signal from being transmitted. And Prialt is a very strong calcium channel blocker that you could actually infuse in the spinal fluid. However, other than Prialt in a intrathecal pump, the main way that neuropathic pain is being managed now, when you're talking about non-pharmacologic devices, is stimulators. And stimulators have come a long way. So like 20 years ago, the spinal cord stimulator was not very effective at all. It helped if someone truly had nerve pain in the arm or the leg, which was due to hypersensitivity. And that old term used to be called RSD, reflex sympathetic dystrophy. Now they changed the term because they realized that it wasn't always caused by an overactive sympathetic nervous system. So now the new term is chronic regional pain syndrome. But at any rate, stimulators in the past were somewhat effective for nerve pain in the arms or legs, but they weren't very effective for pain in the neck and the low back. Now, spinal cord stimulators over the last decade, just like our technology and our computers and our cell phones have gotten a lot better, the technology and stimulators have improved significantly. So spinal cord stimulators are one of the best things that you can use for decreasing nerve pain. And again, you would do a trial connected with an external battery for a week. And if it made a huge difference in decreasing the nerve pain, like more than 50%, then that person would be a good candidate to actually have an implant where you connect it to a small rechargeable battery. However, it's got to be a significant difference. I've seen too many patients where they had a spinal cord stimulator trial and they were so desperate for pain relief that when you saw them a week later and you asked them how much relief they got from the stimulator, they said, oh, I think it helped a little bit. Yeah, maybe 20 to 30%. Those patients absolutely not get an implant because it's not going to work for them, because the spinal cord stimulator trial is as good as the nerve pain relief is going to be. So if it only helped a little bit, like 20 or 30% during the trial, the implant's probably not going to work as well. And it's not going to be worth the pain and the hassle of getting a surgery to get a rechargeable battery planted in your body. But if the spinal cord stimulator trial decreased the pain significantly by like more than 50%, and usually when a spinal cord stimulator trial is really effective, when you see them the following week, the patient's like saying, I really wish you didn't have to take this out, right? Because it's helping them so much. Those are the type of patients that should get an implant. They'll do well. Now, for central pain, and this is the last thing I'm going to say, because it's such a broad topic. I mean, we could talk about this for more than half an hour easy, but there's the last thing I'm gonna say. For central pain, when spinal cord stimulators aren't effective enough, they actually have stimulators that they place in the brain. And there's two categories that are using now. They have deep brain stimulators, which are usually placed around the thalamus, because the thalamus is the part of the brain that's basically the sensory relay center, right? And so they have deep brain stimulators that can be used for central pain. And now they're actually even using cortex stimulators on the surface of the brain. And the advantage of the cerebral cortex stimulators is that there's less risk, because obviously it's not being inserted deep into the brain matter, right? So there's less risk for serious side effects. And the technology in the brain stimulators, whether it's a deep brain stimulator or a cortex stimulator, is again, just like the spinal cord stimulators, significantly improved. Now, brain stimulators really should be done probably like an academic institution, because that requires a high level of expertise from a neurosurgeon to be able to do that effectively. But for central pain, when everything else has failed, including medications and even a spinal cord stimulator, that can be a lifesaver. Before you go to that extent, though, for brain stimulators, fortunately, they have what's called transcutaneous or transcranial stimulation, right? It's kind of like a TENS unit, but they actually apply surface electrodes to the scalp. And they have magnetic stimulation, because some people believe in magnets, as far as it's kind of like acupuncture, kind of like improving, like, the function of the body that the magnet is next to. Whether it's magnetic stimulation or transcranial stimulation, that's been found to be effective in several research studies. And so again, before you go and have like a brain stimulator inserted, whether it's a deep brain stimulator or a cerebral cortex stimulator, you would try obviously the non-invasive brain stimulator devices first, whether it's a magnet or whether it's transcranial, because if those work, just like a TENS unit, if a TENS unit works for you, you don't need a spinal cord stimulator. If a magnet or a transcranial surface stimulator decreases your central pain, then obviously you don't need a deep brain stimulator. So just wanted to leave it at that, but that's kind of like a broad summary of the different things that are available.
Thank you so much. That was a lot of excellent information. I really appreciate that. I know somebody put in the chat about nerve ablation. Oh, you're muted.
So let me talk about ablations, nerve ablations. So nerve ablations are something that we commonly do when we're dealing with chronic axial spine pain, right? Because radiofrequency ablations, which is localized heat, has been used for a long time for people who have chronic neck or back pain due to degenerative facet joint disease. In the old days, they used to inject corticosteroid in the facet joints just like they would a knee or a shoulder. But the limitation is that the facet joints in the spine are so small that there's not much cortisone that you can inject to them. And so even if people got relief from cortisone in the facet joints in the neck or the back, it tended to last just a few weeks instead of like several months or longer.
Gotcha.
So what we do now, it's in fact the most common way to treat chronic neck or low back pain due to facet joint disease, which we call axial spine pain. In other words, it doesn't radiate to your arms or legs, it just stays around the neck or the back, is the radiofrequency ablations. Because the radiofrequency ablations, unlike corticosteroids, where even when they work, typically last on average about 3 months, radiofrequency ablations on average last 9 months to a year. And what you're doing is you're actually cauterizing the medial branch sensory nerves that live above and below the facet joints. They gradually disappear after a couple weeks. And once they're gone after a couple weeks, then the pain is decreased until they regenerate. So on average, it takes 9 months to a year before those medial branch sensory nerves above and below the facet joints have regenerated enough where they can transmit pain again. though you can repeat it as soon as 6 months, because in some patients, it may not last as long as the typical relief. So just like anything in life, the average is what the majority of patients experience, which is 9 to 12 months relief. You have some patients where it may last only 6 months. You have 2 years. But it's a very safe procedure. And before we ablate, we actually stimulate to make sure that we're only getting activation around the spine, and we're not getting any activation in the arm of the leg, because that shows that we're in a correct place and safe place. Now, there are ablations that are done in other parts of the body now. Like they are doing ablations for chronic knee pain. They're doing ablations for chronic hip pain. They haven't done that. Ablation procedures for chronic shoulder pain has not actually been done that much, though they're working on coming up with a procedure for the suprascapular nerve, because the suprascapular nerve is the main sensory nerve to the glenohumeral shoulder joint. One other thing I do want to mention, though, is again, technology has improved so much. There is actually peripheral nerve stimulators that they're using, and it's through a company called Stimware, STIMWAR. And what's nice about these devices, which my partner, Dr. Quave, has some experience with, is you can place these peripheral nerve stimulators wherever a person has severe chronic pain, and in a majority of those patients, they'll actually provide them relief. So what's nice about it is, unlike the spinal cord stimulators or the brain stimulators, where you're kind of like just restricted to the central nervous system, these little peripheral nerve stimulators, and the most popular company right now is, like I said, the company called Stimware. You can place it wherever they're, having nerve pain, and it should provide significant relief in that area. Now, again, it has to be nerve pain. So if it's nociceptive pain, like sometimes people have severe shoulder pain due to rotator cuff pathology or adhesive capsulitis, because you're, using your shoulders a lot if you are a para, with wheelchair use. Then a peripheral nerve stimulator probably is not going to help for that, because it's specifically for neuropathic pain, not nociceptive mechanical pain. But if the problem is a rotator cuff problem, then you can treat that just like a non-spinal cord injury patient. So you can, inject that with cortisone. If that doesn't work, then an orthopedic surgeon can just oftentimes do an arthroscopic surgery that's minimally invasive and take care of the problem that way. But yeah, I just wanted to answer the question about ablations. Ablations in pain management world, we typically do ablations most commonly for axial neck or low back pain, where it's not radiating and it's not nerve pain. It's nociceptive, physical, mechanical pain due to arthritis in the spine, right? Though they are using it now for some arthritic conditions in the knees, hips, and they're eventually going to start doing it for the shoulder. The shoulder ablation really hasn't been perfected yet.
Gotcha. Well, thank you for sharing. Yeah, that's some great information. At this point, I'd like to open it up to anybody that's willing to either share their experience or has a question. Feel free to unmute yourself and go ahead.
I've got a question. Oops.
Yeah, hey, Hannah.
Hey, so like I know if I break my foot, I'm only gonna feel it up in my chest. But does that's still mechanical pain, right? Even though
Absolutely. Yeah, absolutely.
Is that what referred pain is?
So that's a good question. So referred pain is mechanical pain, mechanical nociceptive pain that which is different from radicular pain, because again, these are terms that are commonly used, and yet patients and even some doctors, unfortunately, will use them like they're synonyms, like they mean the same thing, but they're actually different.
Mm-hmm.
It's just like dependence and addiction are different. So that is a form of referred pain, what you talked about there, where you have in the foot of exhibiting itself in a different area, right? Radicular pain, however, radicular pain is when it's an actual pinched nerve that's radiating to whatever body part it supplies, right? So if I've got a disc herniation, a classic example, in my neck and it's pinching a nerve root, then I'm going to have radiating pain down my arm and my hand. That's radicular pain, right? But if you have an injury like in your foot, and like I said, if you all injure your foot, but you feel it like in your stomach or somewhere around your trunk, that's referred pain, because that's not being caused by nerve pain. Like you said, it's being caused by mechanical nociceptive pain. But because of the spinal cord injury, you're experiencing it, in a different way than you would expect.
All right, but you would still treat it like mechanical, or because it is mechanical.
Yeah, absolutely. So I would try to treat that. That would be a good situation where, like, if you try the anti-inflammatory and, they want to try, like a muscle relaxant nerve pain medicine, it's not working. Absolutely. You got a fracture, you got a broken foot. You need to treat that with opioids for, at least a couple weeks. Fractures typically heal after 4 to 6 weeks. So if somebody needed to be on opioids for like a month, that would be, again, perfectly understandable. But that's the type of situation where even though a person has a spinal cord injury, that acute pain due to a fracture, which is mechanical and nociceptive, may require opioid management until that fracture heals for the next month. And it would be perfectly appropriate to prescribe for that patient. So, yeah, I mean, that's the type of situation where, unfortunately, again, I see it too often where there's so many doctors that aren't comfortable prescribing opioids. I understand we have to be responsible with it. A fracture, anybody who's had a fracture, I mean, that pain's severe. That pain's severe, and it's probably not going to be managed adequately with just the anti-inflammatory, because we're not just talking about like somebody, who, their degenerative joint disease flared up, or they got a contusion or a bruise. I mean, if you got an actual fracture, then in that type of situation, just like a non-spinal cord injury patient would be prescribed opioids because anti-inflammatories are not enough. Spinal cord injury patients should be given the same level of care. Again, with a realistic timeline that after a month, they're probably not going to need it, because by that time, the fracture will be mostly healed.
Okay, cool.
Yeah, I actually had experience in this about 8 years ago. I broke my leg, and I can't feel my leg, but the fracture was causing me so many issues and a lot of autonomic dysreflexia and super extreme high blood pressure until I did treat it with pain medication, and then everything would like mellow out, for a little while until the pain medication would start to wear off, and then everything would start going haywire in my body again. So I had to treat for about a month through while the fracture healed.
Yeah, and that's absolutely appropriate. Yeah, because autonomic dysreflexia, as you know, that's a serious complicated cord injury world, right? That's way more dangerous than opioids, right? Because untreated autonomic dysreflexia, when you don't take care of the noxious stimuli, right? Whether it's a decubitus ulcer, whether it's an ingrotoenail, whether it's the fact that your catheter is blocked, right? Or you have a UTI, or you've got a fracture that's not being appropriately managed with pain medication. Yeah, autonomic dysreflexia, that's a way more serious condition than prescribing someone opioids for a month.
Yeah.
Huh.
Thank you. Is anybody else have any questions or experiences they want to share? If you're not comfortable talking, you're more than welcome to put them in chat and I'll read them.
I guess one experience when I did fracture my foot, one thing I've noticed when I have an injury like that, that's when my spasticity gets really crazy. And I had a lot of luck with the diazepam. Yes. And I didn't end up using like, I don't know, an opioid, there's the word. I didn't end up using an opioid, but I did use the diazepam. And that helped quite a bit, actually let my leg chill out. So that's my one feedback.
Yeah, exactly. So again, opioids, they tend to be prescribed when the non-opioid medications have failed, right? So you start with the anti-inflammatories. That's not enough. You go to muscle relaxants, and if it seems like there's some neuropathic pain elements like burning or tingling, then you may try nerve pain medicine too. But if all that fails, then yeah, that's when you would go to the opioids. In your case, like I said, you had to go to a strong muscle relaxant, but that muscle relaxant, in this case Valium or diazepam, was effective, and that's all you ended up needing. And then you didn't end up needing to have to go to the opioids for pain relief, which is ideal. What we don't want to do, if we can avoid it, is have a patient on both benzodiazepines and opioids together, right? Because because if you're on both, then the risk of both central nervous system depression and respiratory failure is higher, because both of those have the possible side effects, both class of medications. And then when you combine the two, the side effect risk goes up significantly higher. Like it's not just additive, it's actually more I wouldn't say exponential, because that may be like going too far, but I'll say this: it's very rare for somebody to pass away from just benzodiazepine. So if they're just taking Valium or Klonopin, it's very rare for a patient to pass away, to stop breathing, if they're just on that medication, as long as it's a reasonable prescription dose. The one exception to that, of course, is alcohol, because you should never drink alcohol with benzodiazepines or opioids for the same reason. But if someone is not drinking alcohol and they're just on a benzodiazepine, whether it's Valium or Klonopin, the risk of someone having severe respiratory compromise where they stop breathing, it's actually not impossible, but it's pretty low. When patients, though, are taking both benzodiazepines and opioids at the same time, then the risk is significantly higher. And it actually is considered the #1 reason why patients pass away from accidental overdose, is because they were on both opioids and benzodiazepines at the same time. Now, there are certain situations, again, because we don't live in a perfect world, there are certain situations where either because the spasticity is really severe or the anxiety is really severe, the only thing that works for a patient is a benzodiazepine, right? And yet, there are also certain patients that are in severe pain and they need opioids. What I tell those patients is, if it really can't be avoided, at least take them several hours apart. And in that type of situation, I would probably be reluctant to prescribe them a long-acting opioid, because that will always be in their system. And I would try to manage it with a couple short-acting opioid pills, with the understanding that to the patient that, look, if you have to take a Valium or you have to take Klonopin, try to take it several hours apart from the opioid. But in an ideal world, and more often than not, we try to avoid patients on being on both classes of medications, because the risk of severe respiratory depression is much higher when both medications are being used simultaneously. Again, there's certain situations where it can't be avoided, when people have severe anxiety or and nothing else manages their anxiety except for the benzodiazepine. But then that situation, you want to take the medication several hours apart. I would say a minimum of 4 hours apart.
Okay.
Yeah, to touch on your point earlier that you were talking about, I'm definitely one of the subgroups of spinal cord injuries that that my spasticity was, just unbearable, and it actually made it hard to enjoy life at some point. And I was on max dose of oral Baclofen and the Tazanidine, and still having such like severe spasticity that it was hard to really do anything. And like any movement would trigger spasms where I was kicking my shoes off. I fell out of bed once from it. And so I did end up getting the intrathecal Baclofen pump, and that's been life-changing for me.
Absolutely. Yeah. And that's the type of situation where it's medically necessary. Yeah. Because when people are on max doses of multiple oral muscle relaxants, one, like in your situation, it wasn't effective enough. And two, they tend to have more side effects like drowsiness.
Yeah.
So it's kind of
terrible.
like they're in a situation where they're on max doses, they're falling asleep, they can't live their life, and it's still not controlling their spasticity. And it's like you said, like causing them to like fall out of the wheelchair or fall out of the bed. Yeah, in that case, Baclofen pumps absolutely necessary.
We have a question in chat. Is the risk mainly moderate to high dose of both long-term or even smaller dose short-term or in acute rehab for SCI patients?
Okay, so can you repeat the question again? Are they talking about opioids specifically, or?
I could just ask the question.
No problem.
I guess what my question was is, I mean, I know that there's going to be a risk if a patient was on both at the same time,
Right.
regardless of how long it is and everything, but are you mainly talking about like long-term at home or at all, like at any dose of both at the same time?
So ideally, you don't want to be on, again, both a benzodiazepine and an opiate at the same time. Short term though, it's probably allowable. Because I've even seen some spine surgeons, the older ones actually, but I've seen some spine surgeons that prescribe like Valium 10 milligrams 2 times a day for severe muscle spasms, and then they send them home with hydrocodone too. Like older spine surgeons, they were just trained that way, you know? And I think because, you know, back when they were trained like 30, 40 years ago when they were doing their residency, I mean, we weren't dealing with the opioid epidemic like we are now. And so, yeah, that was considered acceptable, you know, when they were going through their training. It seems like, you know, more spine surgeons that are like my age, which unfortunately I'm middle age now because I'm about 50, they tend to fall away from prescribing Valium, like just like a knee-jerk response. They usually try to prescribe a muscle relaxant that's not a benzodiazepine along with the opioids. But like I said, I've seen it prescribed even by spine surgeons, though they tend to be older, and you know the patients are doing okay with it. So I think short term, if somebody was on it again for like, you know, a month or less, and again, it was a situation where nothing is controlling the or relieving the muscle spasms except for the Valium, and they had a severe injury like a fracture, or they're recovering from significant surgery where they need an opioid pain pill for a few weeks. Again, I think it's allowable, but in that type of situation, you would still counsel the patient to try to take the Valium and the opioid several hours apart. You wouldn't want to be popping them both at the same time, because that's really when the risk is higher, when you're taking them both simultaneously. You would want to take them, if you could, at least 4 hours apart, because that way the peak effect of one medication is starting to subside before you take the other one, you know? Now, if you have to be on it long term, that's where the risk really becomes high, you know, because it's just the longer a person's in that situation where they're taking both opioids and benzos, then over time, just the risk slowly accumulates where they can eventually have a severe problem like respiratory depression, where they stop breathing, God forbid, in the middle of the night. Now, with opioids, there's quite a number of medical research articles have shown that opioids for chronic pain is not that effective, okay? And I think even though, you know, there are patients who have failed neck surgeries, failed back surgery syndrome, which are on opioids, and they are on opioids for the rest of their life, and those type of patients probably need to be. In spinal cord injury patients, even though, like I said, when you have an acute injury, you absolutely, if non-opioid pain pills have failed, opioid pain pills should be prescribed, just like if you're a non-spinal cord injury patient, for, you know, a couple of weeks or even, you know, up to a month. But in chronic pain situation for a spinal cord injury patient, I would think that most board certified pain specialists, myself included, would not recommend being on opioids long term if you have to be on a benzo, right? Because a benzodiazepine, in this case Valium, for your spasticity, is way more important. And the opioids over time, because you build up a tolerance, tend to lose its effect. So I think opioids are very effective for severe acute pain, right, due to a fracture, short term for several weeks. But if you're on opioids for several years and you have to be on a benzodiazepine for your spasticity, I think most most board certified pain specialists would recommend weaning the opioid, because most likely your chronic pain won't be much worse. And yet you'll be much better off from a side effect safety profile, because you're describing a situation where the person has to be on the benzodiazepine. And that's a more important medication for spasticity than opioids for chronic pain management. I see a lot of testimonials, and it's absolutely true. If you go online, where there were spinal cord injury patients that were on opioids for several years, and then they finally were counseled, or they had side effects, and they had to wean off of it because they were on a benzo, diazepine for spasticity management. And when they were graduating down, not only were their withdrawal symptoms mild, but they actually said that when they were finally off the opioids, their chronic pain was not worse. And their thought process was so much clearer, and their constipation, their bowel dysfunction was so much easier to deal with. So I think for acute pain, opioids should be prescribed for spinal cord injury patients, just like non-spinal cord injury patients. But in a chronic pain situation, especially if a spinal cord injury patient has to be on a benzodiazepine, they shouldn't be on opioids.
Now, I have a question. Sorry, Hannah.
Oh, you can go ahead.
Is Baclofen and Tazanidine considered a benzo?
No, neither one are. And that's why they're preferred.
Yeah.
Because they will not cause respiratory depression. They won't cause a person to stop breathing. And they're not addictive.
And so they also will not interact with an opioid then?
They can interact. You can still have side effects.
Yeah.
But they won't have the serious side effect of respiratory depression where someone stops breathing in the middle of the night. They won't do that.
Yeah. Go ahead, Hannah.
You're mentioning how opioids, you build up a tolerance for them and whatnot. Is diazepam and benzos, are they the same way? Do you need more and more with continued use?
Yes, that can happen. And a tolerance, I also need to clarify this because there's so many different terms in medicine. Tolerance is not the same as resistance, right? Resistance is often used when we're dealing in infectious diseases and antibiotics, where resistance means it's just not going to work, right? It's not going to work at all. That's resistance, right? Where you tried an antibiotic and it used to work for UTI and doesn't work anymore because the bacteria got resistant. So you have to switch to a completely different medication. Tolerance means that it requires a higher dose to have the previous effect. In this case, analgesia or pain relief. So tolerance doesn't mean that it won't work. It just means that you have to go higher in dose. The problem, the danger is that when you're talking about chronic pain in a spinal cord injury patient, you have to go higher on the dose. Now, again, you're just increasing the risk for serious side effects like respiratory depression or compromise. You're right. In benzos, that can happen too. Though it's not as common to benzos as it is to opioids. It's more common, at least it's been in my experience, it's more common for people to develop a tolerance to opioids than to benzodiazepines, though it can happen with benzos also. However, as far as if somebody is using benzos for spasticity, then I don't think they develop a tolerance to that. I think if the spasticity is not being managed by the benzos anymore, there's something else that has happened that's caused the spasticity to get worse. Okay. Just if somebody has autonomic dysreflexia, something has happened that is outside the norm, right? And you gotta have to try to figure out the cause of that instead of just brushing it under the rug. So in my experience, and this is also with Baclofen pumps, if somebody all of a sudden their spasticity got worse and they're requiring significantly higher dose of Baclofen pump, they have a bit of a tolerance to the Baclofen. 9 times out of 10, they have a bit of a tolerance to the Baclofen. It's because something has caused their spasticity to get worse. Whether it's like the catheter's kinked, whether it's like they've developed a syrinx, like, you know, that's grown significantly larger in their spinal cord, you know, or they have a huge disc herniation that's gone undiagnosed and causes spinal cord compression. More often when the spasticity has gotten worse, it's not that they've built a tolerance to the oral medication, whether it's a muscle relaxant or benzo, or whether it's a Baclofen pump. It's because there's a new problem. And that has to be worked up and ruled out before someone just says, oh, it's just a tolerance to medication, we just got to increase the medication. Because more often than they'll miss the real cause. So as far as benzos developing a tolerance for spasticity management, I usually don't see that. Where I see people claim they've developed a tolerance to benzos is when they're using the benzos for their severe anxiety. They don't feel like their anxiety anymore. That's usually when I see patients, I think I've developed a tolerance to benzos, which in that situation, because I'm not a psychiatrist, you know, I tell them that they have to make an appointment with a psychiatrist or get a referral if they don't have one to manage it, because there are other ways to deal with anxiety than just benzos. You know, that's where, like, when you're talking about non-pharmacologic management that also has nothing to do with procedures, that's where, when it's depression or anxiety, that's where those treatments, those treatment strategies can be very effective. The most effective treatment actually for either depression or anxiety is actually not medication. It's something called cognitive behavioral therapy, it's CBT. And that's where they are trained by a therapist or a psychologist how to deal with their depression or anxiety through cognitive behavioral means and not medication. That actually has been shown to be the most effective treatment for depression or anxiety, not medication. Cognitive behavioral therapy, otherwise known as CBT, which, you know, shouldn't be confused with CBD. Obviously, that's something different. But CBT, cognitive behavioral therapy, that's very effective. That's where you're using those treatment strategies that are non-pharmacologic, non-procedure related. And if someone's like saying that my anxiety is no longer controlled, you know, by my benzo, whether it's Valium, Klonopin, or Ativan, instead of like just increasing the medication, which you may do temporarily if they're not on an opioid. As long as they're not on an opioid, then you know, the risk is low for serious side effects. But it should be temporary, and they should be referred either to a psychiatrist or a therapist to manage their anxiety with non-medicinal treatment modalities. Like I said, cognitive behavioral therapy. If you can find a psychologist or a therapist that is an expert in CBT, that is more effective than any medication you could be prescribed when it's done properly.
Awesome. So speaking of CBDs, has there been any studies on CBDs and neuropathic pain?
Yeah, and there's been some studies that show that it's been helpful. Because CBD, which is, you know, one of the components of the cannabis and marijuana plant, definitely has medicinal benefits. It has definite medicinal benefits, CBD. What medical practitioners like myself and urine drug screens that are, you know, ordered all the time, whether it's in a clinic or even in a sports setting, what they're testing for is not CBD. Actually, I mean, you may already know this. They're testing for THC, and THC is what's considered the addictive component of marijuana. Okay. So as long as someone's using a pure CBD product, right? Yeah, can have definite medicinal benefits and can be helpful in some forms of nerve pain or neuropathic pain. But you don't want it to contain THC, because THC is what's going to cause your drug screen to show up positive for marijuana. And THC is what can, cause a person to become addicted to that THC containing substance. And THC, from a medical legal standpoint, it's still considered a Schedule 1 medication or substance, which means that it's still considered illegal from a federal standpoint. So technically speaking, because the DEA is a federal institution, and the DEA is what issues medical licenses for doctors in the United States to prescribe controlled substances, right? Like opioids or benzos. Doctors who have their licenses from the DEA to prescribe controlled substances are not supposed to prescribe when a person is using what the federal government considers an illegal substance.
Gotcha.
And THC is still considered an illegal substance. So CBD is fine, hemp is fine, right? But it's specifically THC that's being tested for in the urine drug screens, because it's considered to be the addictive component in marijuana, and it's still considered illegal from a DEA federal standpoint.
So in your practice, have you seen that CBD can be a good treatment for neuropathic pain?
Yes, in some patients it has. In fact, Dr. Quaid, the head of our clinic, actually has a product called Full Spectrum Hemp Oil, which not only has CBD, but has the other potentially medicinal benefits in the hemp plant without THC. Like, it is truly like 0% THC. It is completely THC free. So the Full Spectrum Hemp Oil product, you have all the benefits of not only CBD, but the rest of the hemp plant without any THC that will cause a person to fail urine drug screen. And the only problem is that compared to like some of the over-the-counter CBD preparations, this particular product, the Full Spectrum Hemp Oil, is a little bit more expensive. It's costs like $90 a month, but you'll get all the benefits of CBD and the rest of the hemp plant, and you'll never fail urine drug screen.
And now that's something that is not covered by insurance, correct?
No, unfortunately, it's not. So it's something that the patient would have to pay out of pocket.
Yeah.
Yeah.
And now
it's not. I use this kind.
Yeah, that looks like
lotion.
It's pure CBD.
It's really cool.
Yeah, that looks fine as long as it doesn't have any THC in it. You won't fail urine drug screen, and that should give you some benefit.
And now to touch on something else you were talking about before the CBD, you were mentioning like if you had a patient that has a Baclofen pump and their spasticity is like all of a sudden going through the roof, and you're thinking it's something else is causing this, not the tolerance to the Baclofen.
Right.
That's where it gets hard for somebody with a spinal cord injury, especially at the cervical level, because we can't feel from up here down. So when something's going on in our body, like we don't know, and sometimes like we'll go to our doctor and be like, I don't know what's going on, but something's different. And sometimes that message is very hard to convey over because we don't know what's going on, even though our bodies are trying to tell us, something's bothering you and you need help fixing it. So that's where it gets really hard, I think, between the doctor-patient level at times, is like when we're trying to get across like something's wrong, but we don't know what it is.
Right. So again, the key factor is the severity of the change, right? So if it's a sudden severe change in your spasticity, where it was fine, relatively fine, and all of a sudden, like the legs, the arms are out of control again, right? And in that type of situation, that would be considered a medical emergency, because it's such a sudden, drastic, severe change that it needs to be evaluated in ER setting, because it could be that the Baclofen pump is shut off. It could be that the catheter is completely kinked, or it could be that somebody has a huge disc herniation all of a sudden that's compressing their spinal cord. And that's not something that can wait to be seen in your clinic the next week, or even like in the next couple of days. That's a true emergency. Now, If it's a situation where it's more like, it's not severe, it's not sudden, it's not causing me to fall out of my wheelchair or my bed, it's just I'm starting to feel tighter now, right? Then that can be seen like in a clinic setting, right? Like ours.
Yeah.
And that it just needs to be properly worked up, which means that you need to not only check to see if the pump battery is still functioning, to make sure that where it may need to through interventional radiology at Asante, for instance, because they have a very good interventional radiology department. You have to do what's called a intrathecal pump catheter dye study, which will show if there's leaks, which obviously then all the medication is not going into the spinal fluid, or if there's a kink that's preventing the medication from going through the catheter like it should.
Yeah.
But yeah, in an emergency setting where like it's a severe change, yeah, it probably needs to go to the ER, where they typically would do a CAT scan because it's so fast, easy. But in a situation with spinal cord injury patient, really an MRI is necessary. Now we all know, like if you have a pump, that the MRI will cause that pump to temporarily pause, but that pause almost always is less than an hour, and then it automatically turns back on. You know, so like I said, the key is the severity. If it's sudden and severe, then just like any other emergency, it needs to go to the ER to get properly evaluated, because there may be a situation where you can't wait a week, you know, to get checked out. But if it's a gradual worsening, then it can be managed in the clinic, and we can just go through the steps to check the pump, to check the catheter, and then, you know, to check the rest of the spinal cord to make sure that things haven't gotten worse.
Got you. Thank you.
Yeah.
I know we're just hit the 7:30 mark. Is there any other last minute questions before we let Dr. Kim go? I want to respect his time, and I thank him for being here.
Oh, it's my pleasure.
Yeah, thanks, Dr. Kim. That was really informative.
No, my pleasure. I see Michael. Hey, well, good to see you.
What's going on, man? Yeah, I definitely wasn't expecting you to be here.
Yeah.
Oh, we got a couple
yeah,
people.
good to see some familiar faces. Not just like see, but Anna. Oh, that's great.
It looks like Michael and Victor raised their hand. If you guys have a question, go ahead.
Yeah, no, like, and I know, see, when I first got my pump, no one ever told me that if my pump were to stop working, that I could die.
Right.
So like, aside from like the major spasticity kicking back in and stuff, are there other major like withdrawal symptoms or anything like that would happen if the pump stopped working?
Yeah, so if the Baclofen pump suddenly stops working because, you know, God forbid the battery just died, or it's rare, but sometimes the rotors in the pump will get jammed and stop turning, right? Fortunately, the vast majority of the rotor failure is because somebody was not using brand name intrathecal baclofen. That's why I insist on brand name intrathecal baclofen. I don't like using compounded intrathecal baclofen, so that's why I always recommend it get filled, you know, by the hospital, because they only use brand name. They use Leorosol, okay, which is a brand name intrathecal baclofen. They use Gablofen. If it's brand name, it's made so strictly by the company that there aren't any impurities in it that could cause the rotors to fail. So usually you don't have to worry about the rotor failure if you're using a brand name intrathecal baclofen, which all our patients do. But yes, a battery could still fail. That could happen to anybody, even if you're using brand name. And if it fails, it is serious, because not only will the spasticity get worse, but what can happen is that the spasticity, the rebound spasticity, can become so severe that your muscles break down. If the muscle tissue actually breaks down, it releases a lot of that protein from the
I
muscles
think you
that
and I were
broken down,
talking about this
and it
last
causes
time.
a condition called rhabdomyolysis, right? Rhabdomyolysis, when that happens, you have all this excess muscle protein in the bloodstream that then goes to your kidneys and it causes kidney failure because it's too much protein for the kidneys to be able to filter. And if the kidneys failure, then that can cause other organs to fail. And it can just become a domino effect. Another thing that can happen when people have Baclofen pump stops working is not only will the spasticity get worse, but it can actually cause seizures, right? So it can affect not their central nervous system, right? Because the spinal fluid is used to having this intrathecal baclofen, right? And all of a sudden, if the spinal fluid is not having the intrathecal baclofen, then it causes that signal to get transferred from the spinal cord into the brain, and the brain can just have a massive seizure called status epilepticus, which, God forbid that happens, and they're not taken to the ER quickly enough, that can relate to, brain damage or even death. So it is scary when
How
a
long would
pump,
all of that take? Like
so it usually, it doesn't usually happen in a matter of minutes. Okay, usually that type of situation will take at least several hours, and up to half a day to a day to really exhibit itself. But when the Baclofen pump fails, it will make an alarm. You won't have to guess. Like the Baclofen pump will make a very loud alarm telling you that it's no longer functioning. Okay, like and when you hear that alarm, and it sounds kind of like like an ambulance type alarm, one, call our office, but two, then call the ambulance to go to the ER. Because if you go to the ER, the advantage of the ER is that they are not just dependent on giving you oral medication. They can give you IV medication, which, as we all know, works quicker and is much more effective. So get control of you having seizures, oftentimes first they'll give you oral Baclofen, right? That's the first thing they'll do. But if that's not enough, then they will give you like IV Valium, Clonopin or Ativan to make sure that your chance of having a major seizure episode is very low, because that's what they treat seizures with, right? Is with Valium or Ativan. So if that situation, it will start beeping really loud. All of a sudden, you're gonna start noticing this tightening of the muscle of your body, and you call our office to give us a heads up, but then you call the ambulance to get rushed to the ER, because once you're in the ER, they'll be able to manage the situation, not just with oral pills, but with IV medication. So it makes the chance of you having severe spasticity causing rhabdomyolysis and kidney failure, or severe seizures that can lead to brain damage or death. It makes the chance of those serious life-threatening situations, the chance of that happening much lower. Okay, because the ER setting, they're used to dealing with those type of situations all the time. They're used to giving IV medication. They're used to providing oxygen, even if they have to intubate a person to protect their airway. That's where you need to go if the Baclofen pump fails. But it is scary when that happens. Fortunately, it's very rare. But that's the reason why unless a person absolutely needs a Baclofen pump, like you, Michael, or like you, Casey, that's why I don't recommend it for everybody. Because like you said, when you have a Baclofen pump placed in your body, like you're basically married to that pump. Like that is serious commitment. So it should only be used for patients whose spasticity, like yours, like Casey's, was truly out of control and nothing else was going to work.
Yeah.
Got you. All right. Any last minute questions? Otherwise, I want to thank everybody for coming to this educational forum. Dr. Kim, this was awesome, man. You gave us so much great information, and we're really thankful.
Oh, you're welcome. No, my
I'll have
pleasure.
to rewatch I missed the first hour. I totally got sucked into something.
Yeah, well, this will be posted on our Oregon Spinal Cord Injury Connection website, and I'll send out an email to everybody and let them know when. But yeah, you can rewatch and collect all the good information you missed in the beginning.
Right on.
All right. Thank you, everybody. Thank you, Wada, for putting together a slideshow.
Yeah, that was awesome.
And thank you for all the participants. Really appreciate you guys.
Yeah, no problem. I'll see you soon, Kim.
All right, very good. Thank you, everybody.
I get.
All right, take care.
Bye.
Take care now.
Bye.
Bye.